Welcome back to Solitary, Poor, Nasty, Brutish, and Short. This week, Scott sits down with Dominic Wilkinson, Professor of Medical Ethics at Oxford. He is the author of Ethics, Conflict, and Medical Treatment for Children, and Pandemic Ethics, From COVID-19 to Disease X. His work uniquely combines hands-on neonatal care with ethical analysis of emerging technologies like AI in medicine. Enjoy!
Dominic, thanks so much for coming on to the show.
You're very welcome.
You've published on an enormous range of topics. There's a lot that would be great to discuss. But the first topic I'm drawn to is pandemic ethics, and I was looking at the edited volume which you put together a couple of years ago. So I guess just at a high level, what prompted you to put this together beyond the global pandemic that we all just lived through?
Well, so I've been working in applied ethics for a very long time, writing about ethical questions, about medicine. I've been writing for a number of years about some of the challenges of resource allocation, particularly at the kind of pointy end of medicine, so the critical care when patients are adult patients or children, babies, like the patients I look after, when your resources, so your ability to care for patients, are in short supply, you can't care for everybody who needs it. How do you make those decisions? And those are everyday questions in lots of health systems. They're really fraught in some parts of the world all the time. They're difficult in many parts of the world at some parts of the year. But people have been aware for a long time that we've potentially intermittently faced real crises. So people have been talking about the possibility, what's going to happen when there's the next pandemic? What's going to happen? In particular, people have thought when there's a bad flu pandemic, because we have had very serious flu pandemics in the past. We have regular flu epidemics, but there's been lots of concerns. So people have been thinking about that. So I guess as soon as it became clear that we faced some really difficult times ahead, looking at those pictures of the Italian hospitals being overwhelmed with people in the corridors, knowing the challenges that our health system already faces, it was very clear that there were some very serious questions that we were all going to have to grapple with within the healthcare sector, and then of course in the wider community. So I and some of the colleagues that I work with regularly started writing both some pieces to help the public think about what were the ethical issues, how were we going to think about them, but also to help health professionals and maybe policymakers try and formulate some practical decisions, particularly thinking about the kind of worst case scenario, the idea, what are we going to do if our hospitals are completely overwhelmed, our intensive care units are full? How are we going to make decisions?
I particularly enjoyed Jessica Flanagan's piece in there. So I was just curious at a procedural level, was this the proceedings of a conference, or how did you assemble the articles?
So this particular book was
because there's people from all over the place in there.
Yeah, so it's a collection of academics from across the world who had been writing about some of the ethical issues during the pandemic, and towards the end, as we were kind of coming out of the pandemic, one of the things that we wanted to do was to reflect on some of the learning points, but not.
So they were all written after the fact, right?
So they were, lots of them were based on things that people had been working on during the pandemic, but the book came out within a sort of year or two of things starting to ease.
These weren't published articles; they were all original chapters.
Yeah, they were chapters, and what we deliberately sought were a range of different perspectives. One of the interesting meta issues in the pandemic was about, well, how do we decide as a society, given that there are some very deep differences in approach to some of these questions. I mean, so one of the kind of fundamental issues is, how do you weigh up individual freedom
That's what I'm interested in.
against public health benefit? And kind of at opposite ends of the spectrum, there are those who say, well, freedom is fundamental. You can't sacrifice. You can ask people to do things, but you can't force them to do that for the sake of the public good. And at the other end of the spectrum, there are people who say, no, look, pandemics is not normal business. This is not normal times.
Yeah.
We need to survive this.
Emergency, right.
And we need to resort to some rules that are best for everybody. We need to think about the greater good for the greater number, to draw on the sort of classic utilitarian way of thinking things. So those are kind of very kind of opposing points of view. And of course, there are all sorts of other views in between and other ethical values that people might say, well, look, this is super important. So what we did in terms of the book was to try and bring together some of the different voices within the ethical literature and to reflect on this question of lessons. What things can we draw from the pandemic? The next pandemic will come. We know that it likely won't be the same as the one
circulating already.
Yeah, it won't be the same as the one we've just had. There'll be some important differences. But what can we learn before we forget, before we move on to whatever else is happening in the world?
I think one thing that's particularly interesting to me is the question of just preserving life, like making sure that people can maintain homeostasis versus quality of life. What quality of life are people going to have? So, as far as I understand, COVID kind of unfolded in two phases, or the pandemic kind of happened in two phases. There was the non-pharmaceutical intervention phase from early 2020 until the first vaccines came in about December of 2020, and then were widely available about halfway through 2021. Within the first couple months of 2021, the rollout got quite bungled, and there's a lot of resource allocation nodes to go into there. But within this first phase of non-pharmaceutical intervention, so lockdowns, social distancing, school closures, curfews, masking, basically any kind of public health intervention, whether coercive or voluntary, that is not needles and arms, non-pharmaceutical. Within that, I think one grievance that a lot of people had was about the cost-benefit analysis and the weighing of quality of life concerns against, I suppose you could say, mere preservation of life. So again, not looking at the results, I'm talking beforehand, right? How was this sort of weighed up? Like what's at stake here? How would the bioethicists look at this?
So I guess in terms of one thing, just to step back, when we face novel infectious threats, and although we're talking about novel threats, these types of problems are not novel. So we've encountered them as humans periodically for centuries. And some of the things that we talked about during the COVID pandemic were really very ancient. So these ideas of lockdown, one of the things that people suddenly started reading were these novels, the Camus and but Daniel Defoe, and so going back to
the history of the Peloponnesian War, some of this.
Because quarantining in particular, and isolation was one of the very few ways that you could protect your community. And that's twofold. You have to quarantine those who are infected, or who might be infected, and you're sealing off those who aren't infected to try and stop the influx. And those sorts of measures are they're the front line against a new agent, because whatever is coming, the next pandemic, is likely that we won't have something on the shelf that we can immediately roll out.
About cordoning off the infected.
Yeah, I mean, it's all about, and this was massively, we all became suddenly aware, it's all about kind of flattening the curve, reducing the rate of rise. And the reason that's so important is because if you have a rapid rate of rise, it very rapidly overwhelms your capacity. So whatever health capacity you have within both within your healthcare system, but then within society, that can easily become overwhelmed if the rate of rise is too fast. So what you're trying to do is to slow it, to keep it below a certain threshold level, so that you can deal with it. So that you can provide, because although we didn't have vaccines and we didn't have specific agents for COVID, there were lots of supportive things that we could do to get most people who had COVID through it. I mean, of course, most people who had COVID didn't need to be in hospital, but those who did need to be in hospital mostly were able to get through by provision of oxygen or provision of...
Get through, you mean survive?
Survive, yeah. So, but then the question is, so what measures should we introduce as a society to try and flatten the curve, to try and avoid this problem of being overwhelmed, and how do we weigh up the costs and benefits? And one of the questions at any level when we're talking about public health interventions are about what it is, what's the outcome that we're measuring when we're looking at the pros and cons. So do we lock down? Do we not lock down? Do we do any sort of intervention? What are we measuring to determine if this is the right thing to do? And in terms of health outcomes, often we have these questions about, are we just talking about saving lives, or are we also talking about quality of life? And of course, if we're saving lives, there's a further question about every time we save a life, it's really just extending a life, because of course we all die. So if you save somebody's life, it's not as if they live forever. It just means that they die at a different time rather than at this point in time. So if you save somebody's life, but he'll die tomorrow, then you've gained a day. If you save somebody's life who's going to live for 50 years, you've gained 50 years. And so one of the ways that health economists might look at different types of interventions is just in terms of the number of lives saved. That would be too simplistic, because we might say, look, it makes a massive difference whether you're saving somebody for a day or for 50 years. So we might look at years of life saved. But within our own lives, it's not merely how long we live that matters. For everybody, when we're making decisions, we also weigh up what life is like for us. So quality of life. So one of the ways that health economists have often looked at health or non-pharmaceutical interventions is to combine the two by having some measure of quality of life as well as length of life with different types of interventions. So one of the ways that the modelers who were thinking about, should we lock down, should we socially distance, should we close schools, they were trying to think about the impact on people's lives, both in terms of quantity of life and quality of life. But one of the real challenges of a novel threat. So this is one of the defining features of a pandemic. So I think there are two defining features. One is the scale of the problem.
Yeah.
So the scale, yeah. So the scale is by definition massive, and that creates this problem of overwhelming our abilities to deal with it. But the second is novelty. So the reason why pandemic spread is because there's something changed. It's either a new agent, one we haven't seen before, or it's changed so that it overwhelms our immune system. So, and that both is the reason why it spreads, but it also means that when we're thinking about what to do, by definition, we don't have data because it's new. It's not, but by definition, it might have some similarities with things we've seen before, but it's likely to be different in some important ways. So that always means that early on, when you're trying to make decisions that might be trying to flatten the curve, you're making decisions in a setting of really very serious uncertainty. So there are of course these questions about how many lives might we save, how long might we save lives for, how much impact are we going to get in terms of those who might have COVID versus the negative impact on people who don't have COVID but who are prevented from going to school or working or living their normal lives. So there's that question, which is important, but overlying all of that is lots of uncertainty about what would the impact be of these different interventions. And so the modelers are having to make lots of assumptions about what the impact might be and constantly revise that.
Have you read this new book from Stephen Macedo and Francis Lee at Princeton in COVID's Wake? Or Sandro Galea's Within Reason? Okay, particulars are not that important. I think that one thing I'm coming across in my research now, which looks at legitimacy fractures and how people coming out of a pandemic. My research looks specifically at Australia and the whole of Australia, and then also at New York City, which is what I'm focusing on now. And in the American context, a lot of faith was lost in public health. I think it was something like 30 U.S. states passed measures specifically restricting the ability of their states to enact public health measures during a pandemic. So there's kind of loss of public trust. And one of the main points of grievance or gripe is about some of these costs related to quality of life, where the costs we're operating in an area of great uncertainty at the beginning of 2020. But the costs of doing certain things are, to a degree, certain. If you close schools, you know that the kids aren't going to be in the schools. Maybe they don't get lunches, they don't get pastoral care, whatever. If you shut down businesses, people are going to lose their jobs, their livelihoods, whatever. Whereas the benefits were unclear. So we have a novel pathogen. We don't know how lethal, how deadly, what's going to happen. I think in hindsight and during, but especially in hindsight, what, members of the general public, many members of the general public, and this has led to this whole other sort of weird moment that we're having in America related to public health. One of the, as I said, one of the points of grievance is the insufficient weighing of costs. People felt like the costs weren't given enough shrift, or they're given short shrift.
I mean, I think it's really.
I'm not trying to make like normative policy judgments. I'm just trying to understand, were the costs actually considered, and were they considered robustly? So, a lot of people felt like they weren't.
So often what's at stake in these cases are different types of harms to different parts of the population over different time periods. So here's one way of putting it. We have some effects, some life and death things, some literally life and death consequences of severe COVID for a smaller number of people, though large in the pandemic. I mean, we did see
Sure.
very large numbers of
Yeah.
excess deaths.
Yeah.
Over the period of the pandemic. So we've got very serious consequences for a minority of the population. It's also worth noting that those who are highest risk were often people who were older,
Yeah.
who had significant pre-existing illness.
Uh,
So, and then on the other hand, we're weighing a different type of cost. So a cost, and you talk about quality of life. So not life and death costs. So costs in terms of well-being, but also costs in terms of freedoms. So their happiness, their quality of life might be reduced. And there you've got a much larger number of people. But also those effects are extended over a longer period of time, and also somewhat uncertainly into the future.
Costs will also last for a longer period of time, potentially.
Yeah.
It's totally unquantifiable.
So you've got a problem of commensurability, which is about how do you weigh apples and oranges. So, and there's commensurability both in terms of the negative impact, so life and death type versus somebody not being able to work, or somebody not having to have school from home, or losing some educational opportunities. And so you're weighing very different things to different people across different periods of time. So that's...
What are the two differences? Sorry, quality of life for let's say the kids in this example. What that's the apple. What's the orange?
So the orange is in terms of acute life-threatening life
For the old.
Yeah,
for
I mean,
comorbidity people.
It wasn't just the old.
Sure, but just in the simplified example.
Yeah. So one way I think that some people have been inclined to think about it is that it's a problem of visible, immediate, quantifiable costs against invisible, kind of diffuse harms.
Right.
And one of the reasons why policymakers might make responses to alleviate the oranges, the ones on this side, the acute health cost, is because those they're seeing in statistics every day. So particularly as the pandemic is unrolling, they're seeing on the front pages of the news websites and elsewhere the numbers of deaths, the numbers of hospital admissions. So you've got a very visible, very serious. Everybody accepts the kind of this is very serious. And they're thinking, well, how do we alleviate that? And against that, there's some other costs, other harms that are much harder to measure and more diffuse and more spread out. So part of it is a visibility problem, but there is also this question about, well, how do we weigh these liberty costs, these quality of life costs against life and death? And should we? So one way that you could quantify them so you could just look at quality adjusted life years. You could look at the massive number of people who had small reductions in their quality of life against the smaller number of people who potentially had years of life that were at stake. And so you might try and compare them. But some people at least would say it's a mistake to try and compare these. So there's a classic philosophical thought experiment that philosophers love to think about thought experiments as a way of trying to test put to the limits our moral thinking. So, for example, how many minor headaches across the population would add up to mean that we shouldn't save the life of a child? So there's a classic example of this, thinking about somebody who's trapped in the I think in the original thought experiment. So they're trapped in the electricity room of a massive baseball stadium. The stadium's packed with people who are really enjoying the game, but he's trapped and he's being tortured by some
The torturers.
Well, in this
the-
case, not by torturers, but by there's been some short circuit or some problem.
Yeah.
So if you relieve his acute pain of having electricity going through his body, you'll spoil the enjoyment of all these people who are these many kind of thousands and thousands of people who are enjoying the baseball game.
Trolley problem.
So
what's different about this from the trolley problem?
So the trolley problem, you're talking about numbers of lives. Saving
numbers of
five lives
enjoyment.
versus one life.
Right.
Here you've got enjoyment of a baseball game versus somebody who's in intense pain.
Right, but if you rip him out, then the baseball game's over.
Yeah, and so all these tens of thousands of people will have their enjoyment of the baseball reduced a little bit. If you add up that enjoyment, if you could quantify it, maybe it would look like you should allow the people to enjoy the baseball game. It counts to more than this intense pain. Now, if you buy this thought experiment, the thought is it's a mistake in kind of moral mathematics to weigh up these tiny benefits in enjoyment across thousands of people and say, look, that outweighs it. Maybe there's a problem of comparison here. But these are the sorts of challenges that policymakers have when they're trying to make these decisions. And one of the things about pandemics is that they force these sorts of trade-offs. We're having to trade off between different members of the population, those who are vulnerable, those who are not vulnerable, different numbers, different types of harms, often in a setting of great uncertainty. So we have now the luxury of hindsight, and we can reflect and we can say, okay, well, look, that was obviously a mistake, or that was the right decision. Maybe New Zealand did well. They made the right call. Maybe Vietnam did extremely well. Maybe other places were too slow or too fast. We can make different judgments, but we have the luxury of hindsight. We've got all this data. And those at the time didn't. And they were relying on models, extrapolated sometimes from past pandemics that didn't work out, or the information that was emerging at the time. And I guess one of the challenges in terms of the population's acceptance of decision making is how well the policymakers were able to communicate how they were making these decisions and why they were making on what basis. And there's a real challenge. Among the challenges. So policymakers are having to make decisions at moments of kind of uncertainty. They're really difficult. There might well be division, but then they're going to make a call, and what they're then going to try and do is to persuade people to follow it. So to persuade people to follow their advice, they're then perhaps not going to share all this uncertainty or all the disagreement or all there's this and there's this, because they don't want people to get confused. They want people to do is to stay home and stay in their bubble, if that's what they've decided.
It sounds dishonest.
Well, so that's one of the challenges.
Lack of transparency.
Yeah. So
you got to make it easy to digest, easy to understand.
So I think that's what.
How do you induce compliance?
I think that's what people were tempted to do, and then sometimes they suffer the consequences of that, because they inevitably made decisions that they had to change because the information changed, or maybe actually it became clear that people couldn't do this, or it wasn't going to have the benefit. But when they were making decisions that were changing and people couldn't see why, or when other people were making different decisions, why did all these different countries take different approaches? Was it because they had different data? Was it because there was some fun? It was because there wasn't one answer. These were deeply difficult ethical questions, and they were making different calls. But of course, when the population see that, they see, oh, look, Sweden's doing this. That looks very different to what we're doing. Why can't we be like the Swedes or like New Zealand? You make these comparisons, and then I think people struggle to understand how decisions are made. And as I suggested, as you alluded, sometimes a desire to keep things simple and understandable for people might then appear, at least in retrospect, dishonest.
I mean, yeah. Well, I'm trying to think where to go with it. There's a lot of strands to pull out. If you compare the Australian response to the Swedish response, you see a very different set of, not ultimately that different, but in the further particulars, there's quite a big difference in how these public health measures were enforced, what public health measures were enforced, the extent of coercion versus voluntary participation. But what I wanted to ask you about was, I think one interesting area to go to on the before moving into the the vaccines and the pharmaceutical interventions, on the NPIs is influenza as a model for COVID. I read through thousands of pages of pre-pandemic planning documents for various kinds of influenza, from avian flu up through, the many other iterations of flu in the last 15 or so years. There was, guidance from the CDC, from the WHO, from different U.S. states. Johns Hopkins has this biosecurity center. They had this big set of sort of prescriptive kind of policy guidelines, I guess you could say, about how to address a respiratory pandemic that was published in December of 2019. And that one wasn't about flu. That was title was just like respiratory pandemic was in the title. So it was almost like,
Yeah.
literally months before, or I mean, COVID was already circulating at that point. And to the best of my understanding of these documents, and the policy prescriptions from the last 15, 20 years, much of the pre-COVID guidance related to respiratory pandemics was not followed. It was kind of chucked in the bin, and many of the non-pharmaceutical interventions which were actively recommended against up through the end of 2019 were wholeheartedly embraced mere months later. And that's a little bit hard for me to understand. I know we don't have the documents in front of us, so we're talking into a vacuum here. To a certain degree, you could say that a lot of this stuff was specifically for influenza. COVID is a different, profile, and so it's not going to be exactly the same. But I just found that to be curious, I guess you could say. It's hard to digest. Why was we did plan for this, and yet when the emergency happened, all the pre-emergency planning kind of got jilted in favor of ad hoc policy making.
I mean, so I think that there are a couple of different things going on. So one is that there was some legitimate differences in the way that this was unfolding that made it inappropriate to apply lots of this planning. So in the UK, as you're probably aware, the politicians faced with this pandemic that was coming, we equipped with some of the modeling and suggestions from thinking about pandemic flu were suggesting an approach that would allow the virus to spread through the population, knowing that they were unlikely to have a vaccine anytime soon. So allowing herd immunity to rise, because that once that occurred, that would then significantly reduce the further rate. But as you also know, they many of the politicians, once the public got wind of that there was this question about, are they going to allow the virus to just spread?
Oh, there was a bias to action to do something.
So then there was a massive pushback against this sort of passive, just let it rip, just let the old people die, type attitude. And so they immediately started denying that there was ever any contemplation of it. But it's pretty clear that was on the table, at least.
It was on the table for everyone.
Yeah, of course.
That's how you deal with it. That's how you deal with any kind of pandemic.
Well, it's certainly among the options, because one of the realities is you're not going to have a vaccine anytime soon. You cannot keep people locked up for 2 years
or can you?
Well, if you are lucky enough to be in New Zealand, so we mentioned New Zealand. So New Zealand is.
Well, let's just stay in the UK for a second because
Yeah.
we're both here. So early days. We'll go to Jacinda in a minute. I tried to get into New Zealand. They wouldn't have. I got a special visa to go and everything, and then I then they didn't want me. So early days. The story you're recounting here is, in fact, they were going to do it. They were considering the herd immunity approach, and the public were the ones who said, "No, guys, come on, do something." And they're like, "Oh, what do we do?" And so then they're like, "All right, we have to abate public fear. We have to."
So I think there's
satiate them.
So I think there are two things that.
But what's at stake here? Again, like we're neither one of us are on Downing Street. You're probably closer to it than I am. But in terms of bioethical concern, we're going to impose lockdowns on a population or we're not.
So just
in this specific circumstance.
Yeah. So I mean, just like we were talking earlier, so we're talking about restricting the movement, the everyday life of a population, in order to save the lives of a what seemed like a smaller number of
the acute harm versus
and
the
in
diffuse
particular
harm.
the quite old and often with significant underlying illness. So one of the things, just to kind of zoom out for a second, is that those who are most vulnerable to flu pandemics or flu epidemics every winter are those who've got lots of pre-existing illnesses, who are in nursing homes, who are reaching the natural end of their life, and then there's a bad flu epidemic, and a number of those die sooner, maybe a winter sooner, maybe some months sooner than they otherwise would.
Yeah. And
so what they were contemplating is, well, maybe we just have to allow this to happen. We don't have any magic bullets here. We know the vaccine is going to take some time because the cost in terms of quality of life on the population is going to be so great, and we don't think we can sustain it. So we're going to come back to vaccines, but the vaccine development for COVID was massively accelerated. It was much faster than anybody thought was likely to happen. So the prospect was we're going to have to lock down our population. But as well as the public saying you can't just let the old people die. You can't let people die from this. Just let it happen. Let it rip. So apart from that, there was also very serious pushback from people in the know to say, hang on a second. If the rate of rise of this virus is too fast, because the virus, although those who are most vulnerable are those who are older, who've got pre-existing illness, actually you also affect a lot of people. You have lots of people being admitted to hospital who are not in that group, and you will completely overwhelm your whole health system. So you then won't be able to treat people's heart attacks or strokes, or
they weren't treated anyway.
Well, so we did see some of those consequences because of the effects of COVID on the hospital.
Treatment, there's a ton of this.
But it would have been even worse had the one of the major reasons why they changed tack, but belatedly, was the modelers came back to them and said, look, your hospitals are going to grind to a complete halt. So allowing it to rise in the way that it's rising, it's not just going to be losing a small number of people who are already vulnerable. You're going to have a massive impact on the whole population.
Right.
The whole
The hospitals are
health system.
full. The people who need to go in for normal, maybe not normal, but who would otherwise need to use the hospitals can't use them.
So it's both. All the other illnesses would your ability to look after them would be
Hampered severely.
massively compromised, but also all the other people. So COVID didn't just affect those who were.
You're saying if it peaks too fast, then it goes for the young people.
Well, you get a very large number of people simultaneously. You always have. So again, even in an ordinary flu epidemic, you have some young people, some otherwise healthy people who are affected by it. But of course, if you have an epidemic that's 10 times worse than normal, you'll have 10 times as many other people who are also caught up in this, who are swept up. I was often drawn to the kind of metaphor of a kind of wave or a tsunami. And in that, you asked it.
I like surfing.
Yeah. How did I start? How did I start thinking about it? So, in the late February 2020, in early March, those of us who were looking at these reports, we just could see this wave on the horizon, and it was coming towards us, and the sea was being pulled out towards it, and you knew it was going to come and hit our shores, and it was going to sweep away. The worry was it was going to sweep away lots of us. Lots of us who were working in the health system thought we're going to be swept away too by this.
Creates more openings for junior academics.
Well, it creates lots of openings for ethicists. So lots of people like me sort of thought, well, okay, this is our moment to maybe make a difference. We can help the public think about these really tricky questions. Maybe we can help the policymakers make these tricky decisions. I think it's an open question whether we manage to help the public to think about these questions. I think it's sadly there's a pretty clear answer as to whether we managed to help the policymakers make good decisions, because I just don't think they were listening to people like me. But I'm sure
what would people like you have been saying in early 2020? What were you saying?
Well, so
to the extent that you feel comfortable sharing.
Yeah, I mean, again, it's not as if I would have pretended to know the answers, because there were massive challenges and massive uncertainties. But one of the things that we would have said was, look, there's some really important value trade-offs here. We've talked about some of them already in terms of freedom, in terms of quality of life, length of life, saving lives. We have to be honest about what's at stake and about what the costs are of our different choices, and also about what we don't know. And so I think that's what I would have been recommending, and also to say that the answers to these questions, we're not going to find in any models. The models can't tell us what we should do.
Yeah.
We have to decide. We have to make some really difficult choices, and we will make mistakes, because that's inevitable. You're going to make some big decisions really quickly in a kind of moving field. The wave's coming.
Yeah.
But what we want to try and do is to make the best decisions that we can, and then keep revising them. That I think is the sort of advice that I would be giving to policymakers if we suddenly had a new pandemic. So we should try and learn from the past, but we also need to try and kind of be actively learning now about how we respond.
Are you familiar with the term intransigence, or like defensive persistence?
Yeah. Tell me what you're thinking about here.
I'm thinking about the political consequences of backtracking or policy amendment. So one thing, Dan Andrews comes to mind from the Victoria example, but you just said, like, you talked about dynamism and being flexible and making changes. Within the U.S., it was interesting because of the juridical fragmentation. Different states sort of pursued what they want to do in the same way that Sweden and Australia pursued different tacks. South Carolina and California pursued wildly different tacks. Or Florida and New York, you could say. There's political consequences to saying, guys, listen, we need compliance on this measure. We need you to do this thing. And then time passes, new data comes out, things have changed, and X politician has made a whole point about really emphasizing this measure, this suite of measures. There's political consequences to saying we're not going to do that anymore. And so I think that was also part of the story of COVID, of this intransigence, this refusal to amend or to roll with the punches, shall we say.
Yeah, I mean, I think it was a really difficult moment for lots of politicians, and some, I think, rose to the challenge better than others. I mean, one of the fundamental things, one of the really interesting things, and of course it continues to echo, are these questions of trust.
Yeah.
So, and the reason, one of the reasons is because...
But they lost trust by attempted to keep trust by what some political scientists would say economizing on the truth.
Yeah.
But then they lost trust because of the economization.
Yeah. So I think that's right, that in a number of cases they tried to hold on to trust, and then in the doing so they lost it. I mean, I think the reason is, like, none of us, not even, or not academics, so none of us are directly measuring these things. There are things that we see with our own eyes. We see people become unwell in our street or in our family.
Yeah, yes.
But
we all know someone who died.
But we all need, we're all gathering information from different sources. And particularly when we're talking about the scale, again, the nature of the big information, we're relying on somebody who's collecting all of that and presenting it to us. And then we're relying on other people who are talking to modelers, and they've got people talking to them about what they should do. And then they're trying to present what they think that is the best option. And we have no choice but to trust somebody. And of course that trust is enormously crucial if we're relying on people to follow rules. What we talked earlier about, what was the difference between Sweden and other places, and Sweden and Australia. One of the interesting kind of priors is in terms of the willingness of populations to follow and to trust the things that they were being told by
both super high trust societies, and they were both okay with it.
Yeah,
most, everyone got reelected. Not everyone. Mark McGowan did. Dan didn't, but for different reasons. So
I think trust enormously moderates what you can ask of your population, because if you have low levels of trust, then you're just not going to be able to implement measures that require people to restrict their lives, majorly change their lives in the way that,
or to use the moniker "let it rip" in Sweden. Sweden is a high trust society, right? So and then they were. They accepted this.
So they relied on a lot of voluntary measures in Sweden, and they were able to do so because they had a society that tended to be very willing to go along without having compulsion, without having coercion.
They could rely on the citizens to shame each other if they didn't participate.
I mean, what was striking, I think, about the UK is that actually, contrary to the initial fears, the population were very willing to go along with the instructions largely. We tend to be, within the UK, both very conscious of the health system and the kind of, we depend on it, we rely on it, we recognize it as a very real benefit, but we also recognize some of its limits. So when people were told, look, our health system is at stake, they made very significant sacrifices willingly. So that was a huge advantage for the UK in terms of being able to implement these measures and maintain them for very long periods of time. But one of the challenges was loss of trust, and one of the ways that trust was lost was not in the way that we've talked already. It was through personal hypocrisy, people who were saying one thing and then doing something very different.
The garden party.
Yeah, the garden party and the Barnard Castles, all of those examples.
I don't even know about the second one. I've not studied the UK.
Yeah,
I can imagine. I went to a castle. And
yeah. So those massively undermined people's willingness, because they thought, look, if you're not willing to do this, why should I do it?
What about the sort of fighting words, I suppose, but it's a censorship and villainization. There was at least in the US, in Australia as well, probably in the UK, there was an extraordinary campaign of censorship of online speech. There was a Supreme Court case that came out about this, where a lot of this stuff was put out into the open. There's been, in the last 5 years, an incredible amount of what are called FOIAs, Freedom of Information Act requests, and the extent and the scale of censorship of dissenting narratives, whether they be about the non-pharmaceutical interventions or about vaccines or whatever. There's the Great Barrington Declaration is maybe the most obvious case, and then the villainization of the proponents of those views. So it's not just like, let's just try to make these views as non-visible as possible. Some of this stuff got out. People were going on podcasts, whatever. And there were a lot of ad hominem attacks, character assassinations, kind of bizarre Soviet era exercises in villainization, which I think, my personal opinion is that this also, not only did it undermine the measures themselves, because people are saying, if this is the right thing to do, why do we need to villainize the countermeasure? How does this factor into the decision making? Because this was can we agree that this was an observable feature of what happened over the course of the pandemic? I mean,
one of the really interesting,
and why did this happen?
Epiphenomena is you have this problem of misinformation that is like a parallel pandemic.
So what is misinformation? Who's to say?
Well, so
who determines that? There were academics have opinions, and maybe they diverge. Does that make it misinformation? Many of Oxford academics. Actually.
Yeah. So I mean, and there are different things that we're talking about here. So some of it represents absolutely the kind of range of different views, and there was,
not fair consideration of all the views. So let me simplify the question: how does censorship and villainization of dissenting views fit into discussions around public health measures used to confront a pandemic?
So that's again a really good question. It loops back to this question we alluded to earlier about simplicity and clarity of public health messages, wanting to have a kind of simple narrative
that people can follow. Have a slogan.
So you should definitely mask. You should definitely
wash your hands.
Versus complexity and uncertainty and dissensus and people having different views. And I think when the stakes are very high, when we've got this global crisis, when there is this sense that maybe we really need to keep the message short and simple. We don't need this noise around it.
But the justification, what are the ethics of that? The ethics are that the benefits outweigh the costs.
So broadly, again, it's a different version of the same calculus. It's the greater good. So let's say that this.
So it's a kind of noble lie or
well,
economization of the truth.
Yeah, I mean, so if we think about the kind of the freedom, the personal freedom versus health benefits,
But
calculus that we had with kind of lockdowns, there's a different version of exactly the same going on in this question about censorship. So should we lose a different type of freedom, in this case, freedom of debate about what's the right measures are? Again, it's potentially for the reason of public health benefit. Now, here too, there's questions of uncertainty, and there's the possibility of undermining. So the worry in just the parallel way to the pretending greater certainty than you know, or here pretending there's greater uniformity than there actually is that if the information leaks out or the people change their minds, and then you undermine trust, and because trust is fundamental. So that's I think what's at stake in these debates. I think of course there is underlying this further question, because there was a lot of clearly wrong, factually incorrect information, misinformation that was being spread during the pandemic. That itself, so there's this whole interesting separate phenomenon of how misinformation in relation to vaccines, healthcare, lots of different things, how it spreads, and so that was this kind of separate parallel pandemic, with really serious health consequences.
Well, I'm sorry. The separate pandemic is the one of information.
Yeah, so this kind of misinformation pandemic. So, and it spreads actually in very similar ways, and actually to similar scales potentially. And the consequences are very serious.
Is that an original term, or where can I read more about this?
I mean, I'm sure that other people have talked about this idea, this kind of parallel misinformation. Because
we use the word misinformation. Let's use the example of the Great Barrington Declaration, right? These are, you're familiar, I imagine. These are not, cranks from Times Square. These guys are respected academics. They had, you could call reasonable disagreement. Some of it turned out to be wrong. Some of it turned out to be correct. And yet there was a lot of villainization. It became not about the correctness of the information. It became fundamentally political. So I don't mean to make you repeat yourself. We've already talked about why this might happen. We want to simplify messaging for people. But in any field, it seems like the science itself, or the public health itself, was damaged because you need pushback. You have peer reviewers look at your articles. So like it's not just you decide what you're going to publish and you put it out. You have debate about it.
So I think that's right. And of course,
but that's not what happened.
No. And as I said already, I think the desire for simplicity, the desire to get the public to comply, undermined itself in the long run by losing trust, by suppressing some of the legitimate debate that needed to happen, and by kind of mixing up. So the reason for alluding to misinformation is that there's this kind
there was a lot of crazy stuff as well.
So yeah, so there was all the kind of chloroquine and drinking bleach, and it kind of there was complete. Yeah. So there's this spectrum, and often it's hard to distinguish between kind of legitimate and reasonable dissent and unreasonable and irrational dissent.
You need to allow all of it, and the marketplace of ideas will efficiently filter out the bullshit.
And I think that's one entirely plausible view about how to manage, and it might be the right view about how to manage information in a pandemic.
A free market of information.
I mean, I think that
don't you think the right information will rise to the top?
I think we
or there's so much uncertainty that you can't be sure that the right information will rise to that top?
I think we face some really serious challenges with misinformation, false news, fake news, and the structures of the way that people access information, the structure of the information that we have access to, means that I'm not sure we can rely on a free market of ideas. I mean, again, this is a kind of interesting kind of philosophical tension between maybe the kind of free market libertarian approach to, well, look.
No, I'm not talking about the economy. I'm talking about of ideas.
No. Exactly. But it's the same principle. So you have the libertarian approach. Let people find it. Let the right ideas, the true ideas surface, versus maybe the kind of controlled economy type view. You need to actually put some checks on the information, because you can't rely on, and particularly when the stakes are very high, when you've got potentially your health system is going to crumble.
This side is the one that won, and unfortunately, in a way that had the opposite effect of what it was intended, then you lost the trust. And now we're seeing, in the United States at least, a strong reactionary backlash.
I mean, I think
this is public health measures that had nothing to do with what were discussed. No, just public health in general.
And vaccines. So you wanted to come on to vaccines. I think the vaccine story is really, and the public trust of vaccines is really interesting.
We'll come back to the last question on the MPIs and vaccines. And feel free, I'm mindful of time as well. On the guy in the baseball stadium, would you pull him out? I know that you would write an article about weighing him or not. Would you pull him out, or would you
absolutely
enjoy your popcorn with everyone else?
Absolutely. So how do we think about this problem of weighing up small costs, small harms across very large numbers against very large harms to small numbers of people? Is it right to allow this poor person to suffer in the electrical room in the baseball stadium?
Yeah.
Would it be okay to torture a single innocent child to prevent a terrorist explosion? So these are the same
Sure, experiment on the kids so that we can all have.
So these are the same
versions of the same thing.
They are versions of the same types of trade-offs, and I think, although
you say no.
So I think that there's some.
Don't torture the kid.
Yeah, I think there are some types of trade-offs that it's a mistake to make. So we shouldn't allow certain types of very severe costs to small numbers for the sakes of small benefits to very large numbers. But it's going to depend on just what the costs are. Because after all, the costs to children, and often we come back to think about children in the context of pandemic, because there were lots of kids, my kids, lots of other people's kids.
They got the worst of it.
Who suffered massively and continue to suffer the consequences for them on their mental health, and on their education, their life opportunities. So those are not like the kind of.
But we're not
enjoying
shortening their life, right?
No.
Well, in some cases we were.
In some cases we are. So I think it's a question of what are we weighing up. So small benefits, enjoying baseball for an hour, or I don't even know how long a baseball game is.
Yeah, it does.
Enjoying baseball for I don't care if there's 1 trillion people who will miss out on an hour of baseball.
If the kid can survive, right?
Yeah, if we're going to save a single child instead, we should save the child instead. But if we're going to talk about 1 trillion children who are going to suffer worse mental health and lose out on education.
But I have to, Dominic, that's what happened. There's more young, 4 billion people, 3.9 billion people in March 20 are being locked down, right? The young populations are the ones who are bearing all these diffuse costs. Yes, they're diffuse. So this is hard, right? Because we want to pull the guy out of the electrical shed at the baseball game. Now, I like baseball, but we'll pull him out of the shed. I'll grant you that, right? Okay. the absolute number of young people who are suffering from, I think the benefits were more than just diffuse. They were acute in many cases, particularly for younger children, but also young people. If we're weighing that against saving the old people who have comorbidities, and there's more young people than there are old people, and the young people are gonna procreate, and this gets into questions about the potential for life and whatever. Then by utilitarian calculus, it's almost reversed, right?
So I think it's very. I think you're right.
Or where's my thinking? You think about this all day. I'm just thinking about it, and for this hour-long podcast.
So I think that's right. So a simple utilitarian calculus is going to favor the greater number.
And are there greater number of young people than old people, like the pyramid population, whatever?
Yeah,
I know we have aging populations, but the potential for life. Like, how do you measure this?
I mean, the number of people who are affected by severe COVID are much smaller than the large number of younger people who are affected by lockdown. I mean, I think these are one of the things that we learn from this experience is we gain lots of knowledge about just what the harmful consequences are of these types of measures. So clearly that'll...
Silver lining.
Well, it gives us information that we didn't have before, that I think the decision makers will face even more difficult decisions next time. They have extra information now. They will know in a way that they didn't know before just what they're sacrificing for the sake of those who are acutely unwell, for the sake of keeping the hospitals running. They might make the same decision. They might make a different decision. It'll depend on the nature of the pandemic.
Okay. Now, you brought it up before with the vaccines. So not to spend too long on it, but specific, not just like vaccines in general, but specifically vaccine mandates, which was the sort of cultural flashpoint around the world of COVID. You need a vaccine to go to the pub, to go to work, to participate in the social life or economic life. In New York, federal employees had to get vaccinated. Teachers had to get vaccinated. Excuse me, not federal employees, New York State employees. How do we, again, like what are the trade-offs we're considering? What are the ethical frameworks that are useful here? Is it purely utilitarian? Is it a value-based thing, like this is low cost to you, it's high benefit to the health system, so you should do it? Like what are we considering here?
So the challenges that we have during a pandemic are versions of the same sort of challenges that we have all the time. So we have vaccines that prevent really serious illnesses in children, but also in older people. We get the most benefit from them if large numbers of the population are vaccinated, are immune. The individual benefits of being immunized are relatively small and statistical. They do outweigh the risks and harms. But for any individual person, if everybody else is immunized, your reason to go along is relatively small. You can be a free rider. You can say, everybody else can have the nasty injection, take on the risk. I'm going to benefit from the herd immunity. But of course, the more people who take that attitude, then your levels of immunity within the population fall, and you have outbreaks.
Too many free riders, and the bus runs out of gas.
So we have this challenge that we always see in terms of vaccine ethics, in terms of benefits and harms, and here it's a different version of the same problem that we were talking about before. So the benefits in terms of preventing really nasty illnesses, terrible
on the individual basis, they're far outweigh. I have
And then the harms to a large number of people of the kind of injection and a sore arm and a bit of a fever, or the rare risks of more serious complications
or whatever.
Yeah. So there are those types of ways, but in terms of mandates,
the population level. So why are we going to have a mandate versus not having a mandate?
So the reason for having a mandate is potentially going to depend on what degree of uptake are you going to get without one. So there's no need.
Why not roll the dice? Why have them? Why not just see?
So again, that would be a perfectly reasonable option if you've got time. If you've got and it's in fact exactly the way that most countries think about mandates in children. So because some countries they have various different types of experience. They have various forms of compulsory immunization for children.
Yeah, you've published a lot on this.
A little bit, but and of course, in that setting, you can wait and see. You can roll out your immunization program. You can see what the uptake is. You can see, actually, how many deaths are we getting from vaccine preventable disease? Our voluntary scheme is not working. Maybe we need to do something else. Maybe we need to let's try non-coercive measures let's not reach straight for the mandate. Let's try and encourage people, educate people, make it easier, etc. But if that's not working and small children are dying, and often the people who are dying, sometimes the people who are dying are ones who've made a choice not to have a vaccine, but quite often they're people who are being affected by other people's choices.
But this is the critical thing. I think this is like the thing to consider here, right? It's you have an individual. If whether or not they get vaccinated is not going to affect them in terms of life or death, probably. However, if this healthy person forgoes the vaccination, it's not themselves that they are potentially endangering, it's others. So then the ethical consideration is one of harms. It's not that I'm putting myself in more of a harm's way. I'll have a sore arm or something. That's whatever, I'm putting so that's the consideration that we're really talking about here.
Yeah.
Right?
And that's exactly right. And so to go back to a great liberal philosopher, John Stuart Mill, the only justification for the state kind of imposing itself on an individual's freedom to live their own life is for the sake of preventing harm to others. So that is really why vaccination is different from our other health decisions. We're all, of course, free to make unwise healthy choices.
Is that true from an epidemiological perspective, that if you have enough of these unvaccinated people, that they'll harm the vaccinated people? Like, this is because there's a focus protection argument. So people, whatever, the vulnerable can get vaccinated. But if you have a bunch of young people who have elected to not be vaccinated, then they're still going to harm the vaxxed vulnerable.
So in particular, the worry during the pandemic was that if you were, let's say you were a healthcare worker, and there's some really complicated questions and uncertainties about the duration of benefit of different types of immunity. So natural immunity versus vaccine acquired immunity.
How long it
and
whatever.
And the COVID kept changing, so the immunity benefit from the vaccine only lasts a period of time. So there's some very complicated. But to keep it simply, and this relates to actually something that we face every winter. If you're a healthcare worker working in a hospital, you haven't had your flu vaccine, the risk is that you will pick up the flu from somebody in the street in your family, you'll take it into the hospital, and then you'll give it to the cancer patient or the elderly patient who's on the ward who's got something else, and who now gets flu on top of their pre-existing illness, and they die. And that does occur. It's certain that some patients go into hospital, they acquire infections
more than they came in.
And some of those infections have come from healthcare workers. So the simple the simple argument that applies to flu and healthcare workers and applied to COVID during the pandemic and healthcare workers and some other types of workers was maybe it's a requirement of your job that you take some modest measures to try and protect those who you're caring for. And some of those measures are obvious, like wearing a mask, washing your hands.
Yeah.
If healthcare workers said, I don't want to wear a mask, it's uncomfortable, I don't like it.
It'll mess up my makeup.
Yeah. They wouldn't and shouldn't be allowed to work in the hospital. The question is, does that also hold for things like immunization, or is there something special about
teachers?
Yeah.
Well, it's okay. So kids have extremely low risk for COVID-related complication. The kids are cared for by, grandma and grandpa, whatever. So they got to pass it. Like, where does the chain stop? So
I mean, I think mandates. There were different types of mandates that were contemplated in the kind of phases of the pandemic. One of the types of
but the trade-off, I know we don't need to get into the minutia of what but it's about harm. It's about not doing harm to others.
Exactly right. And so one of the interesting things with the harm principle, that go back to Mill's harm principle, is it's very straightforward that I should be restrained from coming across and doing harm to you. So my liberty is justifiably restricted. But if I'm going to do something that only has a possibility or a probability of causing harm to you, let's say it's a one in...
You drive, I assume. People drive.
Yeah.
You're infecting my air.
Yeah. So
everything we do harmed. I'm killing bacteria when I walk.
So there are different types of threshold. There are lines that we have to draw. And one of the questions is this contribution to herd immunity, is that within the range of harmful actions that I shouldn't be allowed to take, or is it within the range that I'm allowed to take? Because there are going to be different calls about where that line is, what probability, what types of harms am I allowed to cause to others, and it's going to depend. How we judge that is going to depend partly on how we weigh individual freedom to choose not to be vaccinated, against wider benefits. So here we kind of, again, we've got these deep value differences between different ways that people think about these decisions.
What are the ethical issues with focused protection?
Tell me what you mean by focused protection.
If you're vulnerable, you get vaccinated. If you're not, you don't.
So the
people who are at risk should protect themselves. So the people who aren't, or you're saying because if all these people who aren't, then they're going to harm the ones who are at risk. Or is it that they're harming the healthcare?
So one of the worries is that those who are at risk may not be able to protect themselves, so they may not generate a good immune response to the vaccine. Lots of those who are affected by vaccine preventable illness who get most sick, perhaps they themselves they're too young to have yet had the vaccine, or they're immunocompromised. So they might have had the vaccine, but now they've caught this illness from somebody else who could have had the vaccine, who would have mounted a good response, but chose not to. So that's the focus protection argument says, look, those who are vulnerable, they should get vaccine, they should get vaccinated, but some of those can't protect themselves. They need other people also to help them to stay protected.
Okay, I just ask a couple more quick questions. These could go in a lot of directions, so I'll try to keep them quite focused. What are the ethical considerations of aborting a down fetus?
I think we should wind up here because we
That's gonna go for a while.
yeah
That's gonna go for a
we've
while.
talked for an hour and a half,
Yeah,
and I think
that's not a 5-minute answer.
that's not a quick question.
Fair enough. Well, I'll just end on this, which is a way I like to wrap up these interviews. What is your favorite book and your favorite film?
Well, you should have warned me to have a good
favorite book. A favorite.
Yeah, a favorite book.
Fiction, nonfiction. People give their childhood favorites. People give the latest academic books. They read.
So at the moment, one of my favorite books, because I'm rereading it, is Yoko Ogawa's The Memory Police, which I think is a fascinating book about, obviously about memory, but about authoritarian societies, about how individuals respond to that. It's a wonderful metaphor about memory loss, and how we might preserve our identity when parts of our memories are disappearing. So that is a favorite book at the moment. And in terms of favorite film, I still think one of my favorite films of all time is Withnail and I. Just a kind of wonderful British, very, very British film. Wonderful comedy. Do you know it?
I don't know it. You
should definitely.
What's it called one more time?
It's called Withnail and I.
Withnail is a name.
Yeah.
Withnail and I.
Yeah.
I'm going to add it to the list. Thank you so much for speaking with me.
You're very welcome.